All right, Jeremy, you are good to go.
All right, let me start sharing my screen and make sure it's out of presenter mode. And it's in presenter mode, so now it's not going to be in presenter mode. Look okay?
Yes.
All right, cool beans. All right, glad to have everybody here. Happy week of Halloween. Hard to believe we're almost in November as it stands, but I'm Jeremy Hustead. I've been doing Echo. It's hard to believe we've been doing this now for about 4 years. I think it was even before that, but I started doing it about 2020, maybe even 2019. But this is similar to a lecture I did about a year ago. So I'm hopeful that this will help you all. A lot of changes have occurred with when it comes to the ability to prescribe long-acting bupe. Things that, as of a year ago, we were still talking about what possibly would be available soon, and now we have more options, which is great. If anybody wants to stop me while I'm going, just again, either leave a message or unmute yourself or whatever. Since we don't have a case, I thought maybe towards the end of it, we could talk a little bit about cases you've had with long-acting bupe and maybe any challenges you've had or things you want to discuss with the group. So anyways, disclosures, I don't have any financial disclosures. I don't have any pharmaceutical ties now or ever. I have worked with the Brayburn people and the Indivior people just to help like get the REMS stuff approved here. So I've like talked to them, but I don't get like paid by them or anything. We kind of used we had to use them to help get these up and running. We'll talk about the REMS programs being difficult, but they can be a little bit helpful if you're running into barriers in terms of just again being able to give these medicines. They'll actually do like trainings and stuff for your staff if you don't feel comfortable with administering these. All the medications are FDA approved for the treatment of OUD. And currently, I work mainly in outpatient in the IOP program with Laura Lander, some others, including Gina Pisano, who's probably doing group in IOP right now. I also serve as the president of the West Virginia Society of Addiction Medicine. So I know some of you are part of WVCTSI. We've talked in the past about shots and other things, but for those who aren't part of it, who are physicians and you're doing this group, you should probably be part of ASAM. It's the largest physician-led addiction society in the US. So lots of mentors here and appreciate everybody. It's helped over the years. The objectives are one, we're going to just talk briefly about medication options for opioid use disorder in general. We'll discuss the long-acting formulations of bupe, work on a little bit of clinical pearls now that we've been able to use various formulations for a while, which is great. And also, as I did about a year ago, we're going to add some goofy kid/dad humor from my son's big joke book. So it's the big book of silly jokes for kids, 800 jokes. So some of them are rather cringeworthy, but that'll be a good time to pause and answer questions if you want. Hopefully, get a little chuckle out. I originally was thinking of doing like Halloween type characters like Michael Myers and Jason Voorhees and stuff like that, but we went more G-rated instead of hard R. All right, so in general, MAT or MOUD is probably what most people are calling it now, medications for opioid use disorder. So of course, they are the gold standard of treatment for opioid use disorder. So it's really the only efficacious and honestly the only ethical medical treatments available now. So if you're trying to practice ethical medicine, you need to use medicine at this point. If you're trying to run a program that completely prohibits medication, then I would argue that you're not practicing ethical medicine. I would go so far as to say it's malpractice, but that's me. So everybody recommends using these medicines. So every professional addiction society, that includes ASAM, which I mentioned, AAAP, which is more the psychiatrist, but the NIH, AMA, SAMHSA. So pretty much everybody says if you're treating opioid addiction, you need to use medicines at this point. There's 3 medications that are FDA approved. They're all considered the first line treatment for OUD. So of course we do have methadone, tried and true methadone. Methadone's been around since the early 70s. opioid treatment programs. It really hasn't changed the face of how methadone is dispensed. You can't really prescribe it out of an office quite yet, although that actually is something that's being worked on. I think we brought it up before a couple times in Echo, but there is a push to be able to actually prescribe methadone through office-based, through a pharmacy, rather than going through a methadone clinic daily. So who knows, within a year or two, we could be talking about methadone more on these calls. Naltrexone, of course, lest we forget, naltrexone can be very effective for some individuals. Certainly for people that aren't willing to take methadone or buprenorphine, at least consider naltrexone. I think sometimes we criminally underprescribe it when it is a viable option for folks. And lastly, of course, buprenorphine, which is mainly what we're going to be talking about today. Always keep in mind, what are the goals of treatment? So when we get into kind of sticky situations, ethical conundrums, what do we do? So one is we are trying to keep people from dying and from getting very sick. So less people with hepatitis C, with HIV, with endocarditis, with osteomyelitis, less people dying of overdose. So that's a big part of what we're trying to do, obviously. And then number two is we want to try to increase people's quality of life. So folks not just existing, not just kind of strung out, as it were, on medicines or anything like that. We want people to be healthy. We want people to live the best version of themselves that they can. So that's the goal of treatments. So first, goofy kid / goofy dad joke. What time do you go to the dentist? Tooth hurty, of course. So it is more like 4:05, but tooth hurty. So that's a good one. All right. What if we could use long-acting injectable or implantable buprenorphine? So big question. So we do, of course, we're not talking about it so much today, but Vivitrol, naltrexone XR has been around for a while now. I think it was 09 and 010 or around there that it was approved for opioid use disorder. We don't have injectable methadone, which is pretty cool. But what if we could use injectable or implantable bupe? So potential benefits. One, eliminates diversion. So depending on who you ask, especially if, say, somebody's involved in law enforcement, the idea of diversion, just that's something that they don't even want to think about as a potential. So of course, if you have a shot in your body, you can't divert the medicine. There's no risk of IV use. So people will use IV films, people will use IV tabs, people will use IV anything at times. So if you have the shot in your body already or implantable rod, you can't use it IV. The idea of avoiding having to take something daily, which can be kind of a twofold pro and a con. Some people need that reminder every day that they do in fact have an opioid problem. This medicine does in fact help them. It's a constant reminder that I'm in recovery. So smoother course / withdrawal. So potentially, because we're talking about a long-acting medicine, as opposed to taking a film or a tablet every day and kind of getting more of a sawtooth levels in our bloodstream of what the bupe looks like. Questionably more accepted or less stigma. There's a lot of people on shots for various things anymore. Turn on the TV, all these rheumatological conditions, people getting shots. It's just, again, sort of there's less kind of built-in stigma if somebody just has a shot every so often. The ultimate opioid addiction cure. Is this the ultimate thing that we have? Is this the best that exists? Question mark. What are some possible downsides? One is expense. We'll talk more about cost of some of these things, but expense. So if you do not have insurance, or you're not eligible for the SOAR grant, or if you're not independently wealthy, these medicines are quite expensive. I think, some of us have probably tried to get like the GLP-1 meds, which are about $1,100 a month, for weight loss. We're talking $1,500, $1,800, $2,000 a month for these shots. So they're expensive. Side effects. They do have side effects, just like taking a film or a tablet every day. Adherence. So, on one hand, adherence is better in that you have the shot in your body, it's there, you don't have to worry about people taking, a tablet every day. But people can also decide, hey, I had the shot and I don't want to get a second shot for one reason or another. Adherence is a big problem with things like Vivitrol. So the most common number of doses of Vivitrol is one dose. So people get one shot and never get the second shot. So adherence. Difficulty obtaining and administering. So it is difficult for pharmacies, certain pharmacies, to do these. You have to jump through these REMS programs. A lot of Sublocade, Brixadi now is ordered through specialty pharmacies. We have certain local pharmacies. We have the hospital pharmacy. Somehow we were able to get the REMS program for it, but that's difficult. The administering, it depends on the shot, but one's probably a little more complicated than the other, and not every staff member feels comfortable giving these shots. Concern for me is over advertisement. So advertise heavily by big pharma. So, as basically a replacement to films or tabs. So this is, the next frontier, because again, films and tabs are generic. The cost has gone down quite a bit, thankfully. So now this is the follow-up. We don't have patents on Suboxone or whatever. So let's advertise for, LAI injectables. False sense of security and stability. Again, kind of the idea that you get a shot and you're 100% protected and there's no possible way that you could overdose now, or, if you drank, it's not a problem, or this or that. So is there a false sense of security or stability? Potentially. So long-acting bupe options. So what actually is available and what has been available? So one thing, we'll talk a little bit briefly about it, because who knows if it's going to make a comeback at some point. But Probufene was something that was actually available for about 5 years. So this was initially approved in September 2015. It was removed actually right in the beginning of the pandemic. We'll talk a bit about that. Sublocade we have had now in the U.S. since late 2017. It's hard to believe, 7 years of Sublocade. And then Brixadi originally was approved May of last year. And then it was actually Labor Day, it became commercially available. So late August of last year. So we've had Brixadi in the US now for about a year, which is pretty cool. All right, so a little bit about Probufene. So these were implantable buprenorphine rods that lasted for 6 months. So the idea was you put in these little rods under people's skin. It was meant for people on low doses of bupe, and it would last for 6 months there, which is pretty interesting. It was meant for people 16 and older. So that's technically the cutoff. The FDA approval for all forms of buprenorphine is from the age of 16 and greater. So 16, 17-year-olds fine to get bupe. If you're younger than that, it's a little tricky. There's really nothing on label for OUD in younger people. So the idea was you place 4 rods in people's arms under local anesthesia. You had to have special provider training. I never actually had the chance to administer any of these. Dr. Zhang here was the only one that I know that got certified to do this, but I don't think he ever even had the opportunity to put one in. And it was interesting because you could only use each arm one time. So the maximum amount of treatment you had was 12 months being on these implantable rods. So the idea was that's a person, that's their head now. It's an elbow. So you had to find this part of their inner arm, basically. You actually surgically implanted these little rods, which are pretty wild. A little bit like an Nexplanon implant for those that have had the long-acting contraception. And then when you actually, sorry, somebody's I'm getting some spam call in the background. So you put it under the skin, place it slowly. The actual implantation wasn't terribly difficult from what I understand. One of the harder things was actually removing these. So you had to surgically go in and basically make incisions over each of these rods and then yank them out, essentially. So you could imagine how this might not be the most comfortable thing or a really easy thing to do. So that's all we're going to talk about with probriefing, but who knows, maybe a few years from now, it might make a comeback in, different company or something. Any questions about probriefing? And then we'll tell another goofy joke. Any questions? Anybody actually used it? Curiosity. I kind of wish I'd had the chance. It's interesting. It certainly has some downsides. It was about $8,000 for the medicine, and that doesn't include the cost of actual local anesthesia and putting it in stuff. So you can understand it'd be pricey. But no questions. Okay, so another joke. How does a train eat? It goes choo choo. So I like that one. I think it's all right. My son would be laughing. That somebody does. All right. So Sublocade. Sublocade again. Probably most of us have a decent amount of experience with Sublocade now. It's been around for 7 years. Whether it's been available through insurance, it really hasn't been for that long, but we'll talk about it. So this is, of course, an injectable subcutaneous buprenorphine solution. So it goes in the space between basically the outer layer of your skin and your muscle. So you're not putting in someone's muscle, you're putting it in the subcutaneous parts. It has to be refrigerated. It can be left out for up to 7 days. I know a lot of clinics, when they were looking to get Sublocade, they had to invest in expensive refrigerator units with locks on them and things. So that was difficult for people to be able to keep them in their office. The idea is for patients with moderate to severe opioid use disorder, just like all forms of bup. Technically, it's moderate to severe. One of the big limiting factors as of 7 years ago and still today is technically you have to be taking oral bup, or I should say sublingual bup, for 7 days to start the shot. So it's very difficult, if not impossible, to get insurances to approve if, say, somebody comes in from off the street, they haven't been taking any form of bup, and they want Sublocade immediately. You're going to have a really tough time getting it approved that way. So you have to put people on sublingual bup first. Now, of note, this may change. So the manufacturer of Sublocade, Indivior, they are trying to get it so you could administer it more quickly, but the FDA indications have not changed, and certainly the insurance requirements have not changed yet either. So there's 2 doses of shots. There's a 300 milligram dose and a 100 milligram dose, which are placed in the abdomen only. There's an indefinite length of treatment with Sublocade for OUD. We've had some individuals at our clinic who've been on it for about 2 years, I would say now, nonstop every month. 2 years of shots, which is pretty neat. I've talked to some people at national conferences who've had folks on it for 3 straight years. So you can be on it for a while. It is being marketed a lot to various entities, including the legal system, for maintenance during incarceration and planned prison release, and also drug courts to a degree. So there was a big push. It seemed that if you had somebody that was entangled in the legal system, that Indivior was really kind of talking to various jurisdictions and saying, hey, you should consider switching this person over to the long-acting shot, which makes some sense, but maybe also some concerns with the way things get advertised. So some indications on it. It's indicated again for moderate to severe opioid use disorder. You have to be on films first. It has to be used with counseling and psychosocial support, although I would not be surprised if some of these things drop these type of indications, because actually, for those that don't know, like methadone treatment programs, they no longer have to provide therapy. So there's been some changes with SAMHSA. The equivalent, this is a little fuzzy. So the shot itself, what is it equivalent to? It's fuzzy, but it's between about 8 to 24 milligrams of buprenorphine daily, sublingual. So one thing we found with the shots is that it never exactly perfectly lines up. So if you have a flow sheet, the chart, it says, okay, 300 milligrams of Sublocade equals 24 bup or 16 of bup or whatever, sublingual. It never quite exactly lines up that way, person to person. So some people may be more sensitive to Sublocade or Brixadi. Other people, you may have to throw, it seems like you can't give them enough to even reach, say, 16 milligrams a day. So it probably has a lot to do with people's, biology, how quickly they metabolize these long-acting drugs. So it's interesting. One of the interesting things of this. So after steady state has been achieved, so the idea is 4 to 6 months of shots. And I mentioned we've had people that have been on shots for 2 years or more at other places. So people discontinuing Sublocade may have detectable plasma levels of buprenorphine for 12 months or longer. So this is real important. One of the things we noticed early on, we had times where, say, somebody would get 5 or 6 shots, and it was January was their last shot, and then they disappeared for 6 months, 7 months, and they came back in and they swore up and down they weren't taking any, off the streets or anything. They hadn't gotten any films or tabs, and yet they were still testing positive for bup. At first, we were a little suspect, but the more that comes out, the reality is that it will stay in your system for a very, very, very long time. Okay, so again, two-edged, double-edged sword. So can kind of prolong things and, in a way, taper itself. At the same time, sometimes in the legal community, you might have people that get accused of taking illicit bup who really aren't. They just had these shots for a while, and again, it just takes forever to metabolize out of your system. So it's just something to keep in mind. Again, if somebody is saying, hey, I really haven't been taking any bup, and maybe they're testing, for low positive levels, you send it out for confirmation, there is a very good chance that it has been just remaining in their system from a shot months and months ago. So kind of interesting. So a little bit into the administration itself. So you have to put it in the abdomen only. You don't want to put it into somebody's vein. You don't want to put it in somebody's muscle. You don't want to put it too superficially in the skin. So those are all bad, bad things. So if you put it in somebody's veins, you probably cause some fatal embolus and kill them. So don't do that. You don't want to put it in their muscle. I don't know what it would do, but it'd probably be very bad, probably destroy the muscle tissue. And certainly one of the things we see is if you put it intradermally, like right into the skin itself, the top layer of the skin, you'll have these lesions develop, like cavitary lesions where, you have to put people on antibiotics and things. So don't do that. Only healthcare providers who are trained should administer Sublocade. And I mentioned they will do free trainings for people. So they want folks to be prescribing this medicine. They want, clinics to be administering it. So they will send folks out to teach your clinic how to give these shots. They say you're supposed to administer it monthly, so it only comes in monthly Sublocade, but there should be a minimum of 26 days between doses. Here we typically do 28 days because if you get in the habit of doing 30 days, what you generally find is pretty quickly you're going to hit a weekend and it's going to make things difficult. So we usually try to give people a shot every 4 weeks, which is perfectly fine to do. If it's a little bit later, if it's 5 or 6 weeks with the half-life of it and just, again, how long they persist, you're not going to really hurt somebody by waiting longer, but you just don't want to do it make the interval too short. So one of the things is initiating treatment, again, with Sublocade is the first buprenorphine product has not been studied. So you have to have this trial with sublingual before. So you can't just start people, you shouldn't just start people immediately with Sublocade. With that being said, people I'm sure in certain facilities and certainly with colleagues in like Vancouver that I've worked with, they'll do interesting things like do rapid inductions with, say, a Butrans patch, which is the transdermal form of bup. Give that to somebody for 2 days and immediately hit them with Sublocade shot. Now, I'm not saying you should do that, but there are, it's if somebody gets it on day 6, say, instead of 7, it's unlikely you're going to hurt them. It's more of an insurance barrier. And again, technically per FDA labeling, it's 7 days of sublingual, then the shot. Okay. So this is somebody's abdomen, transport plane. So that's your belly button, or if you have little kids, perhaps your BIBO, as we call it. So you're looking at one of the 4 quadrants around the belly button. So you have to pinch up people's skin kind of at an angle, and then you actually have to give the shot basically between your fingers. which is kind of interesting. And you're angling it at a 45-degree angle. So it literally is a syringe. You draw it up, you tent up the skin, you push it in at an angle. So you do have to be kind of careful with it. So if you go deep, potentially, again, you could put it in their muscle. If you go too shallow, you put it right in the skin, and that's problematic too. So it's kind of a sweet spot, the angle of it. One thing to note with Sublocade is the volume is actually a decent amount of volume. So the 300 milligram is 1.5 mLs, which is a decent amount, again, of subcutaneous shot. The 100, which is more considered the maintenance dose, is 0.5 mLs. For those that have ever given Vivitrol is actually 5 mLs, but it's intramuscularly, so slightly different, but it's 1.5 mLs is a decent amount. All right, so the dosing. So the recommended doses, which anyone who's actually given Sublocade, I'm sure you're more than aware of, is you do 300 milligrams to start for the first 2 months, followed by the maintenance dose of 100. So you could almost think of 300 as the loading dose, and then 100 is the goal maintenance dose for most people. So the maintenance dose technically can be increased to 300 monthly for people who tolerate the 100 milligram dose. So again, you've gone from 300 to 100, but they do not demonstrate a satisfactory clinical response as evidenced by self-reported illicit opioid use or urine drug screens positive for illicit opioid use. So technically they want you to go down to 100 starting at the third dose, but if someone's struggling, they say, I just don't feel as well at 100, or, I'm having relapses, that could be a reason to decide to maintain somebody on the higher dose of 300 indefinitely. So this is just a thing. Again, it's very fuzzy, the doses. So 8 to 18 or 20 to 24 in terms of transmucosal, so sublingual doses. But 300, 100, 100 is sometimes an option for folks. Generally, they're talking 300, 300, 100 for people that we see on who come in on film. So most people we have in clinic, we go 300, 300, 100. Sometimes if that first 300 milligram dose, they feel a little like it's too much medicine, we'll immediately drop down to 100. But sometimes you can even have issues with insurance approving if you drop from 300 to 100. So it's relatively inflexible, the dosing of Sublocade, or you only have 2 doses to choose from, basically, literally. But I guess in a way that kind of simplifies things a bit too. And if you wonder why there's no 200 milligram dose, I've asked that to their faces, and they said they just didn't see a big enough difference between the two. So that's why there's a 300 and a 100, no 200. All right, some issues with adverse reactions. So you certainly see things like constipation, which we know happens with Bupe. Keep in mind now that you have things like naloxone, which treats opioid-induced constipation. Medicaid will pay for that, so that's a potential. Headache, nausea, vomiting. With Bupe, sometimes you'll see hepatic enzyme increases and fatigue. The injection site reactions are most commonly pain, some redness, and some itching. So not altogether uncommon to see the pain and pruritus. I'll also say that with Sublocade, you will almost certainly have a bit of a nodule. For particularly thin individuals, you can actually see the nodule under their skin, like say at summertime, and they're wearing a bathing trunks or whatever, swimming trunks, and you can actually see the nodules from Sublocade sometimes. Kind of interesting. The other thing are these case reports of, again, injection site reactions. So things like abscesses, ulceration, and necrosis. Sometimes these need surgical depot removal, debridement, antibiotic administration, and discontinuation of Sublocade. So we have had people in our clinic who we've had to give antibiotics to, for sure. Again, it was probably because it was given a little shallow. So they say the likelihood of serious injection site reactions may be increased, not may, it is increased with inadvertent intramuscular intradermal administration. So too deep, too shallow, not good. So a little bit in the keys of Sublocade. Typically, we use in patients on moderate to higher buprenorphine doses, although I will say when we first started getting Sublocade, we had this worry that if, say, somebody was on 6 milligrams or 8 milligrams, that we might kind of overwhelm them with too much bupe. Because again, if you kind of look at the numbers, that rarely kind of bears out. I've been surprised times that you have somebody on a smaller amount of bupe and they can tolerate the shots just fine. That might be somebody that would probably do well to go to 100 fairly quickly, but it's not always this, again, kind of linear thing where sublingual dose equals shot strength. That makes sense. Again, you cannot start it immediately. You have to do 7 days of sublingual medication before you can administer it. Only monthly at 2 strengths available. So that's all we have is the monthly form. So 300 milligrams and 100 milligrams. You can only give the shot in the belly. You will see these injection site reactions occur, especially if it's placed improperly. You do have to have this REMS program. So the REMS program for the pharmacy and the clinic to administer. So one of the keys with Sublocade is a patient can never go to their local pharmacy and pick it up. So the shot, both for Sublocade and Brixadi, the shot actually has to be sent directly to the clinic. So you cannot ask a patient to go and get the shot. That's a clear violation of REMS. It won't happen. So you have to have it delivered or staff go and get it, whatever. But a patient can never have Sublocade in their possession. Vivitrol, people can't actually go and pick it up on their own. The use as a discontinuation treatment has not been thoroughly studied, but theoretically, this could be a good option given extended plasma levels after discontinuation. So we mentioned you get 5 or 6 shots, and then, the medication, you'll have detectable bupe levels for months and perhaps a year or more in your system. So it bears consideration that it could be very useful for discontinuation. And you'll certainly see case studies out there and studies being done using Sublocade. The cost of Sublocade is about, again, cash price is about $1,750 a month. And actually the costs between 300 and 100 are exactly the same. So if you're having issue with like Medicaid and you're trying to argue like why somebody should be on 100 versus 300, they know this already, it costs the same. So you could argue this is about clinical benefit rather than cost saving measures. For those that are trying to be clever, I would not encourage trying to stretch out like a 300 milligram dose over 3 months by like dividing it up and not giving the entire shot. So there's been reports of like people like getting rid of half of it or using it later. So don't do that. That's a good way to get in trouble with REMS. All right. Any questions about Sublocade so far? Well, again, we'll try to leave some time at the end just to talk about cases. Hopefully most places have been able to order Sublocade and hopefully administer it, but it's a good option. It's been around for 7 years. We've had it in West Virginia Medicaid now approved for 2 or 3. Time passes strangely. So we've had access to it for a while. All right. Questions? All right. Again, stop me if you see anything in the chat. Where do young cows eat lunch? In the cafeteria, of course. So, by the way, my son picked out these jokes, so blame him if any vitriol just directed towards a poor 9-year-old. All right. So, lastly, Brixadi. So it goes by some different names. So we call it Brixadi here. If you're from the European Union or Australia, it was called Buvidal. It still is there. And if you come from research, you may have seen it as CAM 2038. So there you go. So this is an injectable subcutaneous bupe solution, very similar to Sublocade in many ways. Again, it was initially actually approved and used in the European Union since November 2018 as Buvidal. So this was their first approved long-acting bupe treatment. So we basically, in the US, got Sublocade, Europe got Brixadi. So sometimes people get a little scared when it's like, oh, Sublocade's been out for 7 years, Brixadi's been out for 1 year. Brixadi's been out for 6 years as well, just not in the US. It's been used overseas. So it's intended for use in adults and adolescents age 16 or over in the EU, but also here now, of course. So December 2018 is kind of interesting. So it was actually originally approved not long after Sublocade was approved, but there's this thing of exclusive marketivity. So the FDA, let's say you have two of the exact same medicine or very similar medicines, the FDA will choose one or the other and block the other one. So basically, Sublocade kind of got there first. Brixadi tried to be released very shortly after, and they said, no, you can't come on the market for a few years. So it more or less gave Sublocade monopoly. So it was originally the final approval was requested in June of 2020, which if it's hard to believe ancient history, but probably COVID had a lot to do with why it got delayed, and there's also some manufacturer issues. And then it was again finally approved last year, May of 2023, and then commercially available since Labor Day last year. That's pretty cool. So over a year now. So a little bit more into Brixadi. So the idea is, again, it's used for moderate to severe opioid use disorder. There's no refrigeration required for medication, so it forms a liquid crystal gel. So I mentioned with Sublocade, you have to keep it refrigerator and locked refrigeration units. Brixadi, you can just keep it locked up basically in secure cabinets, things like that, whatever your REMS program says you have to do, but it does not have to be refrigerated. So one of the key differences is it has weekly forms and monthly forms. So, and also more dosing options. So you have 4 different doses of weekly. The 8's not really considered one that people maintain on, but 16, 24, 32. And then you have 3 different strengths of monthly. Actually, in Europe, there's even a stronger version than we have, and it's just not been approved yet in the US, but it may be at some point. So another option potentially. It is placed subcutaneously like Sublocade. So again, you're not trying to aim for you're not trying to aim for the muscle. You're not trying to aim for just the superficial layer of skin. You are trying to go subcutaneous. But unlike Sublocade, which is only the abdomen, you can put it in people's thighs. You can put it on top of their butt. You can put it on shoulders. Although in the research world, when we use CAM 2038, they advise us against shoulders because in theory there's less absorption from the shoulders. So generally, we don't really encourage the shoulder. So different areas to use. So the abdomen, very similar to Sublocade. Actually, with Brixadi, you can do 6 spots instead of 4, so you can go midline. 4 spots, I believe. Yeah, 4 spots on each thigh and 4 spots to there on people's rear. So different areas to target, basically. Unlike Sublocade, which you have to give it an angle, it's all self-contained. The shot basically. So you essentially tent up the skin. You put the shot in. It's a little bit like giving like a Lovenox shot. You press it in. When you withdraw it, it brings everything up with it. So you don't have any exposed needle, which is nice. Honestly, I've given 100+ injections of Brixadi or CAM 2038, whatever you want to call it, and it is incredibly easy to give. Probably less chance of going too superficial for sure, as long as you push needle in fully. But generally speaking, I would argue it's a lot easier to give the shot than Sublocade. All right, so in terms of the strengths and how many milliliters it is, I mentioned with Sublocade is 0.5 mLs or 1.5 for the 300. So the Brixadi weekly is as little as 0.16 ml to as much as 0.64 ml. So that's a little bit more than the Sublocade 100. Interestingly, the monthly shot actually is more concentrated. So a 64 milligram shot is actually only 0.18 ml. So that's not a lot of milliliters. It's pretty small. Even the 128 is only 0.36 ml. So that's smaller than the largest one. We'll talk about a little bit about why that is, but the weekly shot uses ethanol basically as a solvent, whereas the monthly uses a different thing, which we'll mention what it is. Kind of interesting in terms of pregnancy. But believe it or not, the weekly shots tend to tend to leave more nodules under the skin than the monthly shots. At least that's what we've seen clinically. I don't know if others have had experiences with Brixadi, but again, total solution volume as little as 0.16 for the weekly, up to 0.64, and the monthly it's 0.18 to 0.36. So kind of interesting. So a monthly Brixadi 128 is a quarter of the volume of a Sublocade 300. Okay. Dose comparability and side effects. New patients are generally thought to be started on a weekly shot and then ideally transition to monthly. Established people, so folks that have been on Bupe for a while, can immediately proceed to monthly. So they don't really need to go from the weekly shot to the monthly shot. So if you've been on films for a while, you can just basically jump to monthly if you want. So again, I would say these are all kind of fuzzy doses, but less than or 6 or less of sublingual Bupe is equivalent to about 8 of Brixadi weekly. 8 to 10 is 16 or 64. 12 to 16 is 24 weekly to 96 a monthly. 18 to 24 is 32 or 128. I mentioned we don't have 160 here in the US, 160 is Europe. That'd probably be more like 20 to 30-ish, you could say. All right. Some adverse reactions that you see, not dissimilar to Sublocade, are injection site pain, headache, the constipation, which you're going to get with potentially any form of buprenorphine, nausea, these injection site issues, including itching, redness, sometimes insomnia, and actually they have a thing for urinary tract infections. Don't ask me why, but I haven't necessarily seen it. All right, a little bit on dosing for new Bupe patients. So let's say someone has never taken Bupe at all before, which is probably unlikely. So people not currently receiving buprenorphine, the goal is to get people to 24 milligrams of Brixadi weekly, if you're doing it this way. So they always recommend people get at least a test dose of sublingual Bupe. So at least 4 milligrams. So we mentioned with Sublocade, you have to be on it for a week before you can get Sublocade. You can literally just get 1 dose of sublingual Bupe before you can get a weekly shot of Brixadi. If someone tolerates it without getting sick, the sublingual of 4, you can start with a 16 milligram weekly shot. After that initial shot, and we do this in the study actually, is we give people a booster shot of the 8 milligrams. So you can do this within a couple days. So you can see this is actually a little bit more complicated in a way than the Sublocade, which is basically here's a month, see you back in a month. So if you're starting with the weekly shots of Brixadi, it's a bit more of an art. So the idea is to administer subsequent Brixadi weekly injections based on the total weekly dose that was established during week 1, and then you can adjust. So the goal is to be at 24 by week 1, and then potentially go up to 32 milligrams per week. People transition from weekly to monthly or from monthly to weekly dosing, or this can be based on clinical judgment. So again, the idea is like 16 is roughly 64, 24 is 96, 32 is 128. The 8, think of it as more of just the booster dose, not really something where you're going to maintain somebody on weekly 8. It just is not going to last in their system long enough. A little bit in discontinuation of Brixadi. So this is something we've been doing in the CTN 100 trial for a while. So I've been using Bupe. The first time I gave the shot, Brixadi, I should say, as CAM 2038 was, it was July of 2021, which is hard to believe. So about 2.5 years before we had it clinically available, but it is being studied. So there's no maximum recommended duration of maintenance treatment. So you can be on these shots for quite some time, just like Sublocade. So we have had folks on, the longest was 2.5 years straight of Brixadi in the study, because again, it hasn't been available commercially for that long. So it can certainly be tolerated for long durations. So keep in mind, if it's discontinued, the extended release characteristics should be considered, and the patient should be monitored for several months for signs and symptoms of withdrawal and treated appropriately. I would say the longer someone's been on the shot, that this time frame should extend even beyond several months. So we've had folks that have had about one person that was on, got 14 shots of Brixadi, I believe, discontinued, and we tried to give them naltrexone to switch them to Vivitrol about 4 months later, and we actually put them into some precipitated withdrawal. So they still had a decent amount of bupe in their system after 4 months. So you keep an eye on people for a while after they stop these shots. All right, so with that being said, after steady state has been achieved, which is 4 weeks for Brixadi, so the weekly Brixadi, and 4 months for the monthly Brixadi, you may have detectable plasma levels of bupe for approximately 1 month for Brixadi of the weekly kind. So you get it for a month of weekly, it'll stay in your system for about another month without getting another shot. And they say approximately 4 months for Brixadi monthly. I would say that it's probably a little longer if somebody's been on the shot for, the longer they've been on the shot, of course, the longer the detectable plasma level, but probably at times you could think of at least like 6 months. So you might notice the tail of Brixadi is probably a little bit shorter than Sublocade's tail, which can be a year or greater. All right. So you can use it on various patients given the available doses. You just need one test dose of sublingual bupe to initiate, not 1 week of sublingual. So that's different. You have these weekly and monthly forms available, which provide additional flexibility. But the goal is typically to have people on the maintenance dose as opposed to just keeping them indefinitely on these weekly shots. The subcutaneous injection can be placed in various sites, not just the abdomen. You do have to have a REMS program. It's pretty much identical to the Sublocade one. So again, people cannot go and pick it up at the pharmacy on their own. It has to be delivered typically from a specialty pharmacy to the clinic where the clinic it is administered. Medicaid, of note, will generally only approve of 96 milligrams max starting dose because, we have our kind of artificial cap of bupe set at 16 milligrams in the state. So they, in general, will only pay for 96, but they will allow for increases up to 128 once at a higher amount. So if you have somebody start on 96, maintain there, and they're still not doing great, usually it's not too difficult to get them get it approved to go up to 1. The cost of shots is pretty comparable to Sublocade. It's around $1,700 a month for monthly injections. So interesting. Any questions about Brixadi? We just have a couple more slides of kind of general kind of pearls. Yeah.
You have a question in the chat box. It says, so starting a new patient, you use weekly injections then change to monthly, but is there any clinical scenario when it would be of use to convert someone to monthly dosing schedules to weekly?
Well, we'll talk about it in a second. Pregnancy potentially is one of them. I assume that we're talking more about if somebody's, say, non-adherent and you want them to just come in for, to be seen more often, like here's the carrot, you have to come in weekly to get your shots. I don't necessarily love that as a reason, but that could be a thought. I'm not as familiar with the cost of weekly shots because I generally am not using the weekly shots. But we'll talk about some potential reasons you might use weekly. All right. Another joke. Why wouldn't the crab share his treasure? Because he was a little shellfish. I actually like this one. I think that's pretty good. So I hope that gets a chuckle. All right, concerns in pregnancy with these shots. So the monthly forms of Brixadi and both doses of Sublocade, which are of course monthly only, so they contain the solvent carrier. I'm going to try to pronounce this: N-methyl 2-pyrrolidone. I hope Mark is not on, but we'll see. So NMP is the way to say it. So this is potentially a teratogen. That means it's not good in pregnancy. So it's interesting. The weekly forms of Brixadi I mentioned earlier, they actually use ethanol as opposed to this NMP. So they're theoretically better in pregnancy. Now, one thing to note is you actually have about 16 to 61 milligrams of ethanol in these shots. So the standard alcoholic drink is 14 grams of ethanol, which is kind of interesting. So my one question is, if somebody is getting these weekly shots all the time, would that potentially show up on like ETS, ETG as if someone was drinking? Potentially. So just kind of tuck that away in your head. Somebody's on weekly Brixadi, potentially might be like more or less a false positive for that they're drinking. There are studies being done conducted on the safety of weekly Brixadi throughout pregnancy, because again, you're not introducing this NMP as a teratogen. You're just keeping folks on weekly shots throughout the duration of pregnancy, and then potentially switch back to monthly shots. There are no controlled trials of monthly Brixadi or Sublocade during pregnancy. However, I will say that there have been individual cases of success, and you you may be able to find a case report here or there regarding this. So, I'm not saying you should consider this, but it's potential. It's not really a contraindication pregnancy. Just like everything now, you don't really have the pregnancy A, B, C, or X or D or X categories. Now it's more patient to patient basis, like what are the risks of being on said medicine during pregnancy. So generally, if someone gets pregnant on the shot, on either of the shots, kind of the gold standard would still be buprenorphine plus or minus naloxone. So if you're answering a test question, but know that it is potentially a viable option to have people on these shots, specifically potentially the weekly shots, because again, it's ethanol based, no NMP in it. There's another question that just popped up. Sorry, I'm not looking at.
So, oh, is there a risk of say that again.
Teratogenicity.
For young ladies who get pregnant on Brixadi and then switch since it lasts a long time in their system?
I don't think as much because, well, I don't want to say there isn't, but I will say there's at least one thing of case reports of people that were on Brixadi, or it's not Brixadi, but specifically Sublocade, and when they learned they were pregnant, they discontinued it. But this was early when Sublocade was first being used, and the kids came out perfectly fine. So it's more so NMP hasn't, obviously we don't study it in people, but it's more like rats where you can see issues where if you expose rats, and actually the exposures for rats are via inhalation and in edible form. So I don't believe they've actually ever given rats like shots of NMP and then see what it happens to the babies. I did a deep dive into like the EPA testing of NMP. So I wouldn't be so worried that, it's not going to be like thalidomide or whatever, thalidomide where, you have phocomelia, kids with small things. It's not going to be like that, or Depakote, where neural tube defects, that kind of stuff. But I mean, theoretically, may be problematic, but I wouldn't necessarily be too concerned about it. Talk about it, potentially the shot is in your system, but all right, hopefully that answers the question. Teratogenicity, that's a great word. All right. Comparing formulations. This is a handy slide, and you'll have access to these slides too. So a little bit, this is kind of interesting about the NMP. Again, this is the teratogen. So in Sublocade, which is a lot, so you actually have upwards of 833 milligrams of NMP in the 300 milligram monthly Sublocade. So that's a decent amount of NMP. In the monthly Brixadi, the highest concentration is only 115. So it's about a seventh of the dose in the monthly Brixadi 128 compared to the monthly 300 Sublocade. So there's that, and I mentioned the ethanol is the ethanol in the weekly forms. So keep an eye on ETG, ETS, but interesting stuff. You're obviously not going to see any NMP in a Suboxone tab. But okay. Clinical pearls, and then we'll wrap things up. Thanks for hanging in there. Person-to-person preference between the two medications vary. So you have some people that are kind of team Sublocade versus less team Brixadi because it hasn't been around as much. So if we're going back to Twilight, so you can pick your team. Oftentimes, when first initiating, additional sublingual bupe is required. So I will say that many people that transition to either of these shots probably will need a little bit of films or tabs just for the initial going from transition from one to the other, because it is different. So taking a film or tab every day is very different than getting a shot once a week or certainly once a month. Monthly Brixadi has marginally less injection site issues, likely due to less medication volume, so you'll see less of those nodules and generally simpler administration, in my opinion. I don't work for either company. Sublocade lasts longer in the system overall, you'd say, and has a longer tail after multiple shots. So again, we've seen detectable 12 for greater than 12 months of bupe levels after discontinuation. So Sublocade probably has a longer tail than Brixadi. Specialty pharmacy for REMS versus local pharmacies. Very rarely will a local pharmacy jump through all the REMS things, but again, it must be delivered to your clinic. Stress maintaining insurance coverage and consider if legal entanglements. So people need to keep their insurance active because these medicines are unfortunately way too expensive. And it is not the best choice for everyone, but when they work, they generally really work really well. So it's a good option for folks. Last joke and then conclusions. Why did Humpty Dumpty love autumn? Because Humpty Dumpty had a great fall. So hopefully everybody did have a great fall because it's about to be winter time. So in conclusion, MAT-MOUD is the gold standard of medical care of OUD and represents the most effective treatment. These long-acting injectable bupe formulations offer advantages. Sublocade and Brixadi are currently available and insurance will pay, including private insurances. Most private insurances will pay for it. Caution use in pregnancy, but not absolutely contraindicated. The medications are not a cure for OUD, but they offer an appealing choice for MOUD for the right patients and situations. And please continue to be advocates for effective OUD treatments. Again, whether it's shots or films or tabs or whatever, just, get people on medicines that work. All right. Does anybody have any questions that we haven't answered so far?
There was
there's
one
my-
other question that says, will rational drug pay for supplemental film when initiating LAI?
You have to request it, but they will. So you have to ask them, but they generally won't just right off the bat pay for it. Some of the private insurances expect people to need sublingual, and they will just pay for it without asking for it. I will say usually people need maybe like 4 milligrams or 8 milligrams of supplemental, so it's not a huge dose. It's certainly not their original baseline dose that they need, but if you ask Medicaid, they will pay for it without too much trouble. So
Alrighty.
other questions, and I'm willing to stay on for a little while and talk about it. I've become the de facto bupe XR guru somehow. I didn't ask for it, but I did. So
I know you mentioned that it was kind of the preference of the provider or patient between the Brixadi and Sublocade. At what point are you seeing or have you needed to switch between the two? Other than monthly, weekly, that type of scenario, but just what
why would you
scenarios
do it?
warrant?
I think the biggest reason I would switch people from Sublocade to say Brixadi is if they've had a lot of injection site issues with Sublocade. So Sublocade, again, it's trickier to administer. You're going to have more lesions in the abdomen. You have less sites. Let's say we take the jump and decide to do monthly, which I'm not saying you should, in a pregnant person. So giving a shot in a pregnant abdomen is a little scary, right? So that might be a reason to give somebody Brixadi in their thigh or their rear end. So you have some more options with it. So that would be a reason. Sometimes people get scared off by things like you'll hear someone say Sublocade, my friend did terrible on it. And you say, well, maybe Sublocade's not right. There is this other option, or vice versa. So those could be a couple different reasons, but you can basically interchangeably give one or the other. So you don't really have to do any kind of conversions or anything. So if somebody's on Sublocade and you want to switch them to Brixadi, you can do that basically when they're due the next month and vice versa. We've done that in clinic now.
And you're using that dosing for like the C max that you had to convert from one dose to the other.
You're getting a little too specific. I'd say is if somebody is on 100, generally that's around 96 of Brixadi. So if like 96 is kind of a good middle of the road dose with Brixadi where you can decide if it's enough or too little. Sublocade, you almost start high and work your way down. Brixadi's, you kind of start middle of the road and you work your way higher or potentially lower, or you just stay where you are. So there's little intricacies with it, but
Sounds good. Thank you.
yep. Other questions? No stupid questions, just stupid answers from me. So there you go. So let's see.
So this is Dr. Miller from WVSOM. I just want to say thank you because from the time that you've had this lecture, we now have scheduled the Sublocade gentleman to come teach our nurses how to give the shots. So
Good.
yes, I just got them. I just got the message from my nursing that they've got 3 dates to give us. So thank you.
You're welcome. Yeah. So pharmaceuticals aren't always that bad, I guess. So yeah. In Brayburn we'll do that too for Brixadi. Quite frankly, Brixadi is pretty simple to give. If I can give the shot, then anybody can give the shot. So there you go.
I like that.
Any other ones at all? So yeah, it's go ahead. Sorry.
Oh, no, go ahead.
No, you first.
I was gonna see if anyone, just ask if anyone had any questions. If not, we'd go and wrap up.
My contact information is on here. I've definitely had people call and ask. The REM stuff is tricky. It's probably best to have a champion. If you're working with a local pharmacy, get somebody there. They kind of have to do a large part of the REMs. So having a champion, someone to talk to, probably having like one case manager designated to do the insurance stuff. It's really not that complicated anymore. We've tried to work with Medicaid, and again, private insurances will pay for both of these now, which is great. So if you want to prescribe them, it's not too hard to do so anymore. So, all right. And a special shout out to Derek, Buffalo Plaid brother. So we're bringing it back on Mondays. But nice to see everybody. Have a safe, happy Halloween. And yeah, stay in touch if you need anything. Yeah.
Thanks, Jeremy.
Yep.
Thank you, Jeremy.
So, yeah.
Just a reminder that our next session is going to be on November 11th, and it will be on the impact of SUD on families, and that's going to be by Laura Lander. So we will see everybody in 2 weeks, and everyone have a safe Halloween.
You too.